Okay, tinnitus, cervicogenic dizziness. The biggest thing is it happens while you sleep. So you'll wake up and have horrible pressure in your head, congestion, tinnitus is loud. You go upright. As the day goes on, it gets better and better, and then you're stuck being re-injured while you sleep again. Okay. And this is what we found here. Just looking at you from behind, your anatomy, well, basically we think we have neck injuries that healed in a way that you don't want them to heal. So here we can see your jugular on the left. You can see the atlas transverse process right there. You can't tell that it's digging into it. In a moment you will. And you'll see this one on the right, and it's being displaced. What's happening is that the styloid process, when you bring your head down, is sweeping the jugular off to the side. Actually, there you can see where the jugular starts, then it sweeps this way, then it comes back, and you'll see that in a moment. Not only that, but the styloid is pushing the atlas not only from right to left, it's making it to where you don't hold the adjustment. So we adjusted you 3 times yesterday to try to get this atlas to come from this tilted up to the left position down towards a more normal position. You feel better, and it's not just when we adjust your atlas. You've had other people adjust your atlas. You feel better, but then again at night, it all comes back. So what we did is we put a collar on you to keep your styloid up, out, and here it is. So you bring your head down, the styloid sweeps that atlas and puts pressure on it and knocks it to the right. And when you're upright during the day, you have gravity helping you drain out of your head. And when you lie down, you don't. So structure affects function. You can see these elongated styloids. You can see how it's bordering that jugular. Here you can see how it's sweeping. Look at how it displaces that around. And you've gotten some postural work done, and it seems like you're not responding like one would think if you corrected your posture. I had a cardiologist that looked just pretty much like this, and he found he had to put his hand under his chin and put his head in the position of Rodin's thinker in order for him to get through the day and think clearly to get the brain fog to go away. And so he would do that throughout the day. And it looks like that's the posture you've adopted to be able to do your job. I mean, you are an MD and an engineer. You're a pretty sharp fella. So your posture to adapt to this doesn't look good. And I understand why you're doing some posture work to try to fix it. But this seems to be the hierarchy of importance, and the rest is just an adaptation to this. Let's see. Let's put some screenshots here where we already dissected you and captured. Again, beautiful shot there. This is an emissary vein that starts off very small. You can see how it's gotten large, and the hole that it comes out of has dilated, so you have an adaptation. Some people have more collaterals than others, so they can adapt to these things better than others. You don't have a lot of collaterals, although it seems to be draining out of your face. But there's a good shot of that adaptation. We won't talk about that here. Good shot of indentation. There you go. There's your displacement. Yeah. That's a really good shot of how it sweeps. And as an Atlas doctor, I've adjusted atlases and made people feel great. Other time you adjust atlases and nothing happens, and I think this is part of the thing. So this is making you resistant to getting an adjustment and holding an adjustment. All it takes is you bring your chin down and you'll put some back pressure and mess it back up again. Subluxate it. Again, I removed the head here so you can see down. We are finding these seatbelt injuries or heavy backpacks. You're a hiker, and we've seen this kind of thing with, we had a guy that had a big snare drum in college, and that thing was so heavy for him, and it always hurt in there, and his looked actually worse than yours. But so the scalenes, which are really responsible for stabilizing the neck, they originate on this first rib, the anterior and the middle scalene, and they attach in through here and keep it so you don't have a bobblehead. So we see these injuries here occur, the scalenes can't modulate correctly, you're more vulnerable, and when you get an injury, it kind of, actually you're just vulnerable, that's about it. Of course, we drew a line through the center of the foramen magnum because we care about putting your atlas in place. Here you can see how far your atlas is displaced to the left, and it doesn't take a mechanic to see how this is kind of driving it. So you'd, in my opinion, you'd want the right styloid. The surgeon's probably going to take the right styloid out first because that's the one that's beating it up and displacing it. And the surgeon's told me about how he's looked in there and seen how the wall of the vein in these cases they're just so beat up. Clearly they've been under trauma for, well, the styloid's growing, so it's more and more trauma as the years go by, and then they're hit a threshold. Yeah. I mean, this is pretty much the main thing we want to talk about. Well, okay, so I've made some measurements here on the atlas. The atlas has gone up to the left, as one would expect, and the difference from the left to the right is, what, a 0.5 millimeter? If I move the atlas a 0.5 millimeter, it opens up, decreases the turbulence of the cerebrospinal fluid that goes through there, and does all kinds of wonderful things. So the difference between symptoms and not symptoms, and a lot of people, is a 0.5 millimeter. This one's 0.5 millimeter. Anyway, you can look at that. But with these styloids, they're a confounding factor. More measurements. Yeah, there's vascular structures. There's how you're adapting your collaterals. You know, okay. Right, so we evaluate for hypermobility. Look, C1 is coming off of C2 a little too much. C2 on C3, you've got an injured joint capsule here. It's not moving like it should. There is some movement in there, but it's calcifying. The rest of them seem okay. Anything we can do to arrest that joint or stop the accelerated degeneration here would be great. And you know, they're doing things with PRP these days and stem cells and all kinds of great stuff. The disc height is maintained, so it's not deranging because of a decreased disc height that's putting a load on it. This is an actual trauma to the joint capsule. Again, left and right head rotation, that same, yeah, so yeah, C1, C2, a little too much. C2, C3, stuck, not moving. So that's what happens, is the vertebra above and below have to adapt. And you can see how much the joint space is, I mean, how much movement is occurring everywhere else. It's just, you got hit there. Same evaluation. You do have some sort of a calcification there from an injury of some kind. Yeah, so we're documenting the hypermobility. Evidence of a contracture in the anterior compartment. You're resistant to having a curve come back, and I think that's the reason. All right, so we drew a line at the top of, from C2 up. Just picture the jugular sitting in front of the atlas. So what do? I want the atlas away from the jugular, and I want the styloids away from the jugular. So this is what you look like when you lie down. Just picture how far forward the atlas is relative to this particular line. And then you can see where it is. Then you go upright, and you can see how far back the atlas goes. So when you're weight bearing, it does drift back pretty good and open up that vein. Then we put an 8-pound weight around you. We moved it another millimeter or two. Your ultrasounds, we'll let people look at that. We did measure your 2.21 styloid there. Airway, yes, your airway's compromised. That's somebody else's problem to figure out, but we did document it. And that is right behind the hyoid, by the way. Remember those styloids are calcifications of stylohyoid ligament. So there's an injury to stylohyoid ligament, so we're seeing a contracture or something pulling back, so that just kind of all fits together. That's it. Anything you want me to talk about? Anything you want to add?
Oh, thank you.
Okay.